Wait. So let's get started. My name is Sun Jae-won. I'm gonna be the moderators, and this session title is Foodborne Illness in the United States, Causes and Costs. And the three exciting presentations are waiting for us. And the first speaker, Megan, will present the influence of the climate change on the vibrios in the United States, projected health and economic impacts for 21st century. And the second speaker, Sandra, will present the cost of the foodborne illnesses in the United States in 2020. Am I right?
I'll explain more.
Okay, you're gonna the other like exciting papers, so which is good. And the last presenter, myself, will present exploring the linkage between the agri food sector production and foodborne illnesses outbreaks. So here is how a session works. So each presenter will present their paper in 20 minutes. After the presentation, we're gonna have the Q&A session in 5 minutes. And a question from the Loom first and question from the Zoom second. And 10 minutes wrap up discussion after the three presentation will be made if time allows. Okay, Megan, the floor is yours.
Thank you so much. Let me make sure I can share my screen here. Okay, are you seeing my presentation?
Yeah.
Great. Well, thank you for the introduction. My name is Megan Sheehan, and I am from Industrial Economics, presenting research funded by the Environmental Protection Agency titled The Influence of Climate Change on Vibriosis in the United States, Projected Health and Economic Impacts for the 21st Century. Our paper was recently accepted for publication in the Environmental Health Perspectives Journal. And this was an effort that included co-authors from the EPA, but also the USDA, including Sandy, who will present in a few moments, Boston University, as well as some of my other colleagues from IEC. So abundant research documents how climate change is negatively affecting environmental and human health and imposes considerable costs. One important pathway is through the prevalence ranges and concentrations of water and foodborne pathogens, particularly for species sensitive to air and temperature, or air and water temperatures that will continue to increase under climate change. Non-cholera Vibrio species whose life cycles are tied to sea surface temperatures are likely to be one such pathogen, and vibriosis infections caused by both dermal and foodborne exposure to Vibrio may increase in the future. To understand what this future scenario might look like, our paper forecasts the number and costs of future vibriosis cases in the United States, specifically from increasing sea surface temperatures. Our approach follows 7 steps that I'll walk through in the slides that follow. In summary, we first aim to understand the historical relationship between sea surface temperatures and vibriosis, those steps that I highlighted in red, and then use that relationship to predict how vibriosis might increase in the future based on sea surface temperatures predicted in various climate models. Then we model those cases, the steps that I highlight in blue. So before we jump into our statistical modeling, however, we first discuss the literature that links sea surface temperatures to the prevalence of Vibrio species to incidence of Vibrio infections. First, we link sea surface temperature to Vibrio species. There's abundant evidence using samples taken from various locations across the North Atlantic and around the United States that link sea surface temperatures to Vibrio in the water. Second, other papers document the link between Vibrio species in the water and then vibriosis infections in human. Given those first two links, research now directly maps between sea surface temperatures and vibriosis infections in humans. This was first done by Semenza et al. Using data from Sweden, as well as Baker et al. In other geographies in Northern Europe. Our paper follows their approach, which maps sea surface temperatures to vibriosis infections, and we're the first to do that across the United States. So the next step was for us to assemble a data set of vibriosis cases throughout the country. That comes from the CDC's COVIS data. Vibriosis became a nationally notifiable disease in 2007, meaning the CDC should capture all reported cases across the United States. This, of course, does not consider cases that never are detected or any cases that were misdiagnosed. Then a large part of our effort was to map those cases to the coastal geography of exposure using information available to us in the COBIS data. So for foodborne cases, we use seafood investigation data to determine from where a shellfish eaten in Minnesota, for example, was actually harvested from. And for waterborne cases, we use information about which water bodies individuals reported entering and any travel that they undertook right before a diagnosis to make a reasonable guess about where they were exposed to Vibrio. This information is not available for all cases, so linking to exposure locations really limited our sample, but in a way that increased our ability to assign the environmental conditions necessary for Vibrio to thrive to those vibriosis cases. The map on the slide here shows how considering the exposure location really changes the shape of our data. On the left, we show the reporting counties tagged with those vibriosis cases, whereas on the right, we show the coastal exposure locations that we assign to each of those reported cases. The graphic here highlights two other important things. First, there was an increase in cases over time, including a sharp increase in 2017 when the testing regime for vibriosis changed. Second, you'll notice that there's considerable variation across Vibrio species, and our analysis considers 4 species and species groups. Vibrio parahemolyticus was the most prevalent before 2017 and is among the most common sources of domestic food-related or seafood-related food poisoning cases in the United States. Vibrio vulnificus cases are low in numbers, but have a very high rate of mortality associated with them. And in fact, the highest mortality rate across all seafood-borne pathogens in the US. Vibrio alginolyticus cases fall between parahemolyticus and vulnificus and are on the rise in the United States. Finally, our Vibrio other category includes all other Vibrio species or those that are unidentified by the lab. Next, we assemble a data set of sea surface temperatures by month in coastal county using data from NOAA. Research demonstrates that sea surface salinity is also an important determinant of Vibrio abundance in water. However, there's very limited data ability and we cannot include that in our historical model. We do assemble a limited data set using the years for which data are available to offer a specification that includes this information, but that model is not our preferred specification for forecasts. So next we develop an estimated statistical model to uncover the relationship between historical sea surface temperatures and vibriosis infections in the US. Given limited variability in the number of cases by county and month, we convert our outcome variable to a binary variable to identify instances where any vibriosis case is identified. This allows us to estimate a logistic regression. We estimate these models separately for the 4 species categories that I mentioned earlier. Here, I only show the model for parahemolyticus, for example, but all of the models take the same form. This is important because different Vibrio species have different temperature thresholds over which they thrive. So we use information from the literature to identify species-specific linear splines for the sea surface temperature variable. We also include state and year fixed effects as controls and cluster our standard errors at the county level. Once we have our historical model calibrated, we then turn to predicting the future. First, we assemble a data set of future sea surface temperatures also at the county level. Then we assemble these data for both RCP 4.5 and 8.5 and across several GCMs, which are specific to the contiguous US, Hawaii, and Alaska. For those of you less familiar with climate impact analysis, RCPs represent different assumptions about greenhouse gas emissions in the future, whereas GCMs represent different climate models that forecast different conditions like air temperature, humidity, rainfall, and in this case, sea surface temperature. The graphic on the right of the slide shows how these future projections of sea surface temperature compare with the baseline levels on average across the 3 coasts. As you can see, sea surface temperatures are expected to rise over time, and more so for RCP 8.5, which is associated with a higher greenhouse gases emission scenario. Then we combine our statistical model from step 4 with our future sea surface temperatures in step 5. We predict the probability of any future vibriosis case in a given coastal county, then scale based on 2 factors. 1, the number of historical cases represented by each binary variable in the COVIS data. And then 2, multipliers from Scallon et al. That account for underreporting, underdiagnosis, and international travel. Then as a last step, we assign cost to those cases. Here we use the USDA's cost estimates of foodborne illness data product based on work by Hoffman et al. 2012. These cost estimates are specific to Vibrio species and offer estimates on the direct medical costs, as well as the indirect costs associated with productivity losses and mortality. The analysis essentially offers 7 health outcomes, the last of which on the slide here is minor unreported cases, which is by far the most common for most of the species. Finally, onto our results. So here I show a condensed version of our regression model output for the historical statistical model. As you can see, we estimate the model separately by Vibrio species, and that each species has a separate temperature range over which we look at the relationship with vibriosis incidence. In all cases, you'll notice a very strong statistically significant relationship, and these are the relationships that we use for predicting future cases. Once we combine those historical relationships with sea surface temperature projections, we estimate between 390,000 and 530,000 total vibriosis cases per year by 2090 across all species, where the range includes RCP 4.5 at the low end and 8.5 at the high end. This represents a 51 to 108% increase in cases relative to a baseline era of the early 2000s. Across Vibrio species, most cases will continue to be parahemolyticus and the other category. In fact, parahemolyticus will increase the most relative to baseline numbers. The graphics here present the trends anticipated throughout the 21st century by Vibrio species and separately by RCP. So what then happens when we assign values to those cases based on the distribution of health outcomes associated with each species? We estimate the total annual cost of all vibriosis cases will reach $5.2 to $7.3 billion in 2090. Relative to baseline, this represents a 140 to 234% increase in costs throughout the 21st century. Given the high values assigned to cases resulting in death, approximately 95% of the total costs are attributed to mortality. The remaining costs are split nearly equally between the direct medical costs and other indirect productivity losses. This also is obvious when investigating the average cost by species. The cost per vulnificus case is by far higher than any others, given that the high risk of mortality associated with that species. So in conclusion, rising sea surface temperatures will likely increase the prevalence and the cost of vibriosis in the United States. In our paper, we also present suggestive evidence that sea surface temperatures may also drive increases in vibriosis cases in some regions, which will result in additional climate-induced human suffering and costs. However, we are unable to offer the future number of cases or costs associated with salinity specifically. We also note that vibriosis has and will result in other non-health related costs, including to the seafood and recreation industries, when restrictions are imposed to prevent the spread of vibriosis at particular temperature levels. Finally, more data on exposure location for foodborne and waterborne cases will both reduce the future cases as well as target closures and restrictions more precisely in the future. And that's all I have for you. Thank you so much.
Okay, let's go to the second presentation. Thank you, Megan.
Sorry about that. Why is this not? Come on. There we go. All right. Very good to be here and join you today. I'm sorry that I'm not going to be able to present new U.S. cost of foodborne illness estimates. I expected we would be done mid-spring, and as sometimes happens with projects, it's taking a bit longer than we had hoped or planned. So we do expect those to come out this fall. They are essentially done, but not quite ready for presentation. So instead, what I'm going to be presenting today is some efforts that I'm working on to help improve the methodology and the empirical basis for estimating cost of foodborne illness in the US. This is work that I've done with colleagues from US EPA, and we all work together to help design a survey that was then fielded by the OECD. So this survey is looking at willingness to pay to reduce risk of chronic kidney disease. And I think as many of you, okay, why is that not working? All right. It's having problems advancing. Before I get into this too far, I want to back up and kind of look at context a bit. So why do we value health and how is it used? Well, one of the major uses of health valuation is in cost benefit analysis. We also saw a very nice example of use of cost of illness this morning, looking at the value to society of private efforts to improve traceability of foods. But I'd say a major reason why federal government agencies at least are involved in a major use of valuation, health valuation is for cost benefit analysis. So from the welfare economics that underlies cost benefit analysis, we know that what we're really trying to do is estimate the willingness to pay to reduce risk of illness or death. And, but that's not what we do. USDA, at least, EPA, many agencies, and many governments around the world use cost of illness. And that's a more conservative estimate, because if we look at how a decomposition of willingness to pay, there was a very nice paper by Harrington and Portney in the early 1980s that broke this down. We know that willingness to pay is can be decomposed into the cost of treatment, the value of lost productivity from time in all uses, both labor market and home production and leisure, plus willingness to pay to reduce the risk of pain and suffering associated with the illness, plus willingness to pay to reduce the risk of death associated with the illness, offset by any expenditures that members of society are already making to reduce that risk. So what you can see is for non-fatal illnesses, what we're typically using is the cost of medical treatment plus lost productivity. And the lost productivity is often measured as lost wages, although it can be measured, we can capture home production and to some extent leisure. And there are other methods that are used that I can talk about during questions, but in general, the point here is what we have for morbidity is an underestimate of what we're actually trying to get. So there's been increasing interest in trying to address that. For death, we have a lot of surveys and a lot of revealed preference studies on willingness to pay to reduce risk of death. And that's how we get our value of statistical life year estimates. We don't have that same body of work for morbidity, primarily because illnesses just vary so greatly in their characteristics. So either you're going to need a wide range of surveys, or really we don't have the revealed preference data to do the valuation on the morbidity. And the, you know, so with death, in conducting these studies effectively, we're assuming that what we're valuing is the event of death. And in general, we make an assumption that the cause of death is not affecting the willingness to pay. That's not, obviously not true, and it's not entirely supported by the literature, but that's the assumption that's made, and the reason why a willingness to pay measure has been deemed as acceptable for deaths. Okay, so there's a lot of interest in getting this, but there hasn't been funding, and a couple of things have happened recently. One is that the OECD has stepped up and said, okay, this is it. We've got to do something about this, and that's what I'm going to report about now. Also, other countries are on the foodborne illness front. Other countries are moving forward with willingness to pay surveys. In particular, the UK and Australia have, and USDA Economic Research Service has come forward with funding to do similar surveys in the US more broadly. Today, because it's a completed survey, I'm going to focus on the work that OECD has been doing. This is coming out of their chemical regulations group, and they're looking at health effects from exposure to chemicals. Because they included chronic kidney disease, and because I was following this work, I got involved because of, as many of you who work in foodborne illness know, some of the Shiga toxin E. coli's can cause kidney damage and chronic kidney disease. So I felt they needed my expertise on chronic kidney disease modeling and communication, and I thought it was important to make sure that we had a survey that was written in such a way that it could be used for foodborne outcomes. So there are a few studies, a few willingness to pay survey studies that have been done on reduction of risk of effectively of end-stage renal disease, or when the kidneys actually shut down. But chronic kidney disease is a much longer process, and it has impacts on health and ability to live a full life. And so we wanted to capture the full, not quite, at least the serious part of the full experience of chronic kidney disease, not just kidney failure. The survey is a standard, has a standard structure of a willingness to pay survey. We talk about why we're doing this, ask demographic questions. We provide background on kidney disease. We provide a tutorial on how we're going to present risk reductions visually within the survey. We ask about people's willingness to pay, and then we do some debriefing questions to see if people took the survey seriously and understood it as we had hoped they would understand it. We use a double-bounded dichotomous choice. So we ask people, we show people a risk reduction and ask whether they're willing to pay a set amount for that risk reduction. If they are willing to do so, we ask a second question in which we raise the price. And if they're still willing to pay, we ask an open-ended question, what would be the maximum you'd be willing to pay? Alternatively, if they weren't willing to pay to pay the initial amount offered, it's dropped. And then finally, if they continue not to be willing to pay, an open-ended question about the maximum that they would pay on the lower end. Like a number of surveys recently, we use a very unspecified vehicle or manner in which the risk is reduced. This survey, as you'll see, was done in a number of countries, and a benefit of this approach is it allowed us not to run into country-specific or cultural-specific issues with the way in which the risk was reduced. we specified that the cost was not covered by health insurance or national health or any national healthcare system. They'd have to pay for this out of pocket, that only the risk of kidney disease would be affected, not the risk of any other disease or any other health condition, and that the risk reduction was limited to a 5-year period. And after that, they would have to do something else to continue to reduce their risk. So the payment, both the payment and the risk reduction was described as occurring over a 5-year period. The payments were made annually, and we also provided information on what that would amount to, the total that would amount to. So we do, as I said, we provide background on kidney disease, on kidneys function as well as disease. The aim of this was to provide it at a level that people with, say, a high school education could understand. And this is kind of the kind of level at which we present it, but we do describe how that disease progresses over time. So the survey itself, in terms of looking more specifically at the way the questions were asked, we're asking about a private good, something they're going to have to pay out of pocket, asking about their own willingness to pay for their own risk reduction. The risks are communicated by a grid that I'll show you in the next slide or in a few slides from now. We use 3 baseline levels by age group and 2 risk reductions, a risk reduction of 2 in 1,000 and 5 in 1,000. The initial bids were $300 to $4,800 over the 2 risk reductions. So this is an example of a willingness to pay question. Suppose it was possible to risk, after we have described what we mean by serious kidney disease, we asked, suppose it was possible to reduce your risk of serious kidney disease, but this would come at a cost to you. Specifically, suppose this will not eliminate your risk of kidney disease, but will reduce it for the next 5 years. Your risk of kidney disease over the next 5 years will be reduced from, and then there's a baseline number that is associated with their age group, to something smaller, and the something smaller is specified. There wouldn't be any other effects. It would only help your kidney health and reduce risk of kidney disease, but otherwise it's not going to have any other effect on your health. The cost is covered directly by you. That is, you need to pay the cost yourself over these 5 years. So how do we define kidney disease for the purposes of this survey? Well, if you look at the medical literature, you'll see kidney disease characterized by 5 stages. But the first 2 stages are typical. While there's a decline in kidney function, they're typically asymptomatic and typically undiagnosed. And so we define serious kidney disease as chronic kidney disease from the point in stages 3 through 5. So that's the point at which symptoms begin to appear through full kidney failure. And we describe this progression in more detail in the survey that I'm doing here. And we also describe what happens we describe treatment that normally happens during those stages, and the effectiveness of treatment in slowing the progression of kidney disease. And we describe what treatment would look like and outcomes would look like if you reach the point of that your kidneys were no longer functioning well enough to sustain your life. So at that point, you'd go into dialysis and wait for a kidney transplant. And we talk about what that entails and what a kidney transplant and life with a transplanted kidney entails. About 65% of those with chronic kidney disease are symptomatic, are estimated to be symptomatic and to have some complications to their health. And about 35% go on to develop kidney failure. And we explain, those rates in the survey. And then we also explain that chemicals can be the cause of chronic kidney disease, including biotoxins from bacteria like E. coli. Okay, we use a grid or these matrices to communicate risks. These have been increasingly used over the last 20 years in stated preference research. And we, prior to presenting them in the willingness to pay question, which I have here, we use them we explain how we'll be using them, how they present risk, and check on people's ability to understand risk by asking them to compare matrices that present two different levels of risk. So we know if they understand, okay, this is a bigger risk than that in this picture. So here is the way in which the willingness to pay question would be presented. We have a baseline or current risk, in this case, 60 and 1,000 over 5 years. And we ask if they're willing to pay, and they can continue in that and not pay anything, or they could reduce their risk to 55 and 1,000 in this particular question over 5 years by paying $240 a year. They make that choice, and as I explained, with a dichotomous choice, there would be follow-on questions. The survey was implemented in the US as well as in 9 other countries. We did pre-testing in 4 countries, and the survey was translated into each language. Bid levels were adjusted using a purchasing power parity exchange rate, and the demographic questions and baseline income categories, et cetera, were all taken from standard categorizations for each country. So now I want to get into some results. So first of all, do we have a decent sample? So in general, the sample, and I'm going to focus on the US results today. So in general, on gender, the samples across countries did a pretty good job of hitting gender targets. I'm being told that I need to go faster. Sanjay, if you would just please tell me if I give me verbally a 5-minute warning. Okay. So, so in the U.S. we are a little bit biased towards females, but not too terribly. About 68% of the sample was female. In general, in the U.S. We exceeded a bit on the 30 to 44 and underachieved our population target on the 18 to 29, and we were dead on everybody 45 and older. So not too bad on the age. All countries showed an underrepresentation of the lower educated respondents. In the US sample, we have an overrepresentation of those with a medium education, and slightly under, but pretty close to target on the high education. On income, generally in the most high income countries, in the US, we pretty closely approximated the population median income for the US in our sample population. So a couple of the things that are important to do in stated preference surveys is to make sure that you've got a survey of people, a sample of people that are taking the survey seriously and that understood the survey. So this presents some analysis that we did on what are called speeders, people that went through the survey so quickly that we think maybe they didn't really take it seriously. And in this case, what I'm going to focus on are the results for speeders for comparing sample behavior to the country-specific median behavior in the survey. And we're going to define a speeder as someone who either took the survey who the length of time it took them to do the survey was less than 48% of the median. So, or the length of time it took them to go through the valuation question was less than 48% of the median. So what we see for the US is that about 3.4% of the sample went through the full survey faster than we would think acceptable, and about 9%, which is a little higher than we'd like to see, went through the valuation questions themselves faster. There's heterogeneity across surveys. Part of that may have to do with language issues, or not language issues, but just differences in the length of time it takes to read a survey in different languages. Okay, so shifting to some results now. So what I'm presenting here are the baseline result, which is a survey using a spike and not including China. There were issues about representativeness of the sample for China that were more significant than they were for other countries. So we explored what effect leaving China out would have. But again, what I want to focus on is the US, and the important things I think to see here is that we're not focusing on, this is overall. Overall, what we're seeing is that an increase in the risk reduction leads to an increase in willingness to pay. An increase in cost leads to a decrease in willingness to pay, exactly the kind of behavior we want to be seeing. We do see a spike, that is the average probability at which people are indifferent to accepting the good or not. Is 4.5%. So across all countries, what we see is a mean willingness to pay of $2,572, and what we're calling a value of statistical case, exactly the comparable concept to a value of statistical life of about $800,000. Let's see.
Sandra,
So
you
what-
have a 2 minutes go.
Okay, so so this is showing the marginal impact. Again, we've got normal good behavior in terms of response to price and risk levels. We see some interesting behavior in terms of if they had not, as expected, if they've not been diagnosed with chronic illness, their willingness to pay is lower, but there's some interesting results here with regard to their perception of health. But I want to go ahead to the US results. In terms of robustness, the baseline, so trying to clean up the sample for people that either didn't take it seriously or didn't understand it the way we thought it would, what we see is that results are pretty robust to those cleanings. They don't make a lot of difference in our results, which we interpret as good in terms of the survey functioning well. So let's look at country estimates then. For the US, what we see is a mean willingness to pay of $2,150, and which implies a value of statistical case of $680,000 US. So that falls kind of in the middle of the pack of the large income countries. We're seeing not a clear pattern with regard to income and of GDP per capita and the value of statistical case. It's rather clustered. So what are next steps? So this has provided us with one survey that provides us with estimates of the willingness to pay for reduction in serious kidney disease. But obviously there are a lot of other foodborne diseases, many that are much milder. Over the next few years, if all goes well, I'll be working with others at ERS and the University of Manchester and Resources for the Future to adapt a survey that was done in the UK that allows us to value a much broader set of foodborne illnesses. The nice thing about this is that for short-term illnesses, it values both the attributes of the EQ5D quality adjusted life year instrument that can then be used. So we'll get attribute valuations that can then be matched to using that same quality adjusted life year instrument to characterize a wide range of diseases. And so if successful, this would allow us to get a willingness to pay estimate for a wide range of acute short-term foodborne illnesses. And then in addition, we'll be doing a wider set of willingness to pay for long-term outcomes for some of the major chronic sequelae to foodborne illnesses. Thank you.
Can I ask a question, Sandy? Or
Yeah.
Yeah, you started off and as part of your introduction, you mentioned that it's important to do these willingness to pay surveys because the cost of illness estimates are normally a more conservative estimate.
Mhm.
So if you use those in regulatory cost benefit analysis, you're generally underestimating the benefits. Have you compared any of these willingness to pays to the cost of illness for chronic kidney disease, and how do they compare?
Yeah, I'm sorry. I had meant to put that slide in, and I haven't. No.
Yeah, I'd be curious.
Yeah,
Any other questions? Okay, let's move on to the last one. Okay, my name is Son Jae-won. I'm the PhD student in the Department of Agricultural Resource Economics at NC State University. The paper I'm going to present address the question of how characteristic of the egg food production affect the risks associated with the foodborne illnesses or outbreaks. This is joint study with me and Barry Goodin and Catherine Boyce. Okay, so I'd like to start with the motivation. So I was surprised by the number. The CDC estimated that each year, roughly 1 out of the 6 people in the United States get sick because of the foodborne illnesses. So I was being in the United States in 5 years. That means I might be got like foodborne illnesses during my program. So which means I was surprised by the numbers. And CDC also estimated 128,000 hospitalization and 3,000 deaths because of the foodborne illnesses. And it brings a lot of financial burden, which is $16 billion annually. So as you know, the incidence of the foodborne illnesses has a lot of factors involved in it. So one of the factors we are interested in is the host factors. So if you say the immune system, so a person who had a weak immune system more likely to get sick because of the foodborne illnesses. This is our focusing point. So instance, the study wants to take a closer look at it, like I just said before, the how host factor will affect the likelihood of the foodborne illnesses. That's because the specific person groups are more susceptible to the foodborne illnesses compared to the healthy persons. For example, senior and children and pregnant women and people with a weak immune system more likely to get sick because of the foodborne illnesses. So to be specific, hygiene condition in the workplace can affect not just workers' health, but also residential health as a community level. So we want to focus on so egg food production is we want to focus on the fact that egg food production is highly involved in the exposure to the chemicals and hazards and chemicals and animal disease we can see. Therefore, residential health condition might be affected by the agriculture activity through the proximity of their residents to the agriculture productions. So our contribution will be the better understanding of the linkage between the egg food production and incidence of the foodborne illnesses at the community level. Let me provide some background quickly. So livestock farming exposure provided a wide range of the health problems such as respiratory disease or something. And as you can see, intensive livestock farming generate multiple pressing health public health issue, including respiratory disease and exposure to the chemical antibiotics and the animal disease. There's a bunch of the researcher that investigated that fact. And as I mentioned earlier, this study focused on how agriculture activity affect the likelihood of foodborne illnesses at the community level, not just the farmers. So there are a large body of the literature discovering that the presence of the livestock farm can influence the regional health. And for example, Boyle paper found a lung disease patient living near the farm has increased respiratory symptoms. Also, the multiple research project figured out that the prevalence of the antibiotic resistance in the animal farms and surrounding environment has been extensively reported. For example, Hills et al. Paper found that less intensive livestock farming lowered the risks associated antibiotic resistance that the residents experience. So another background I want to elaborate is a work environment. So different sector has different work environment, as you can imagine. Among the food industry sector, food processing sector tends to maintain hygiene level of their workplace than the other sector. For example, you can compare to the processing facility compared to the farmers, and you can imagine the facility will, like a processing facility will more likely to maintain their higher hygiene level compared to the farm. So for example, one example we can imagine the HACCP, which is the system that the food safety is addressed by monitoring the entire food processing systems. So, and this is the HACCP is not that incorporated in the agriculture production sector, but the HACCP, so the federal regulation required the food processing sector to implement the HACCP. So therefore, hygiene condition in the nearby food processing facility can affect the community health burden of the foodborne illnesses in the residential area. That we can imagine that one. So let me talk about the foodborne illnesses very quickly. So foodborne illnesses occurred due to the various agents that contaminate the food, including germs and chemicals and toxins. And there's a robust body of the literature investigating the origin of the foodborne illnesses. For example, cause of disease and transmission method, or food vehicles and setting of the exposures. But to the best of our knowledge, no study has investigated the influence of the house factor, which is immune system, affected by agriculture productions on the risks of the foodborne illnesses and immune status in the agriculture setting. Since a proportion of the disease transmitted by the food differ by house factor, if we have a strong immune system, the likelihood of the foodborne illness will be decreased compared to the person who has a weak immune system. So this distinction can better quantify the risks associated with the food-related illnesses. So our research questions, as I mentioned briefly, address the question of how characteristics of the agriculture production affect the risks associated with foodborne illnesses at the community level. We will take a look at the county level data. So we construct a unique county level panel data set that includes rich information on the foodborne illnesses, outbreak and characteristics of the agriculture productions, and health factors and demographic characteristics and food consumption pattern as well. Let me talk about my identification strategy. So we have to measure the livestock farming sector size. We utilize a livestock sales share, which can be calculated by the livestock share divided by total agriculture shares. A second measurement, which is to measure the processing sector size, we utilize labor intensity, which can be calculated by the labor cost over the total cost. Let me explain why the labor intensity can be indirect indicator of the processing sector size. So producer sector and processor sector have a distinct level of labor intensity. Labor intensive processor sector compared to the producer sectors. So that's why we use a labor intensity as an indirect measurement of the processing sector size. And last measurement to measure agriculture sector size general, we utilize a farm income share, which can be calculated by farm income divided by total income. Let me talk about my dependent variable, which is foodborne illnesses related risks, and we utilize the CDC National Outbreak Reporting System data to measure the foodborne illnesses risks. We utilize a four-dimensional foodborne illnesses related risks, which is you can see the number of foodborne primary cases and number of primary cases who visited the healthcare providers, and number of primary cases who visit the emergency room, and which can be, we can think about this kind of more severe situation compared to the just visit the healthcare provider, and the number of primary cases who are hospitalization. So you can imagine that as you go from the top to the bottom, you can imagine the severity of the foodborne illnesses will be increased. Right? If you get sick but mild symptom, you're not going to go to the hospital, just to take a rest at home and drink a lot of waters, and your symptom will be gone. But if you're a severe symptom, you're going to go to the ER or hospitalization or visit the doctor to take care of that one. And CDC defined the foodborne outbreak as the incident in which two or more persons experience a similar situation, similar illnesses due to the ingestion of the same food. They defined that as a foodborne outbreak. And from the 2009 to the 18 weeks, we have 5,000 foodborne outbreaks. But I want to emphasize that we excluded the multi-county outbreaks because of our characteristic of the independent variables. And all the numbers are normalized of the population size, which is divided by 100,000 populations to offset the scale effect. But as you can imagine, that there's a lot of limitation in terms of data set. And only just the data included only reported foodborne illnesses to the CDC, which is conformed to the laboratory testing. But as I mentioned on the first slide, CDC estimated 48 million foodborne illnesses episode every year, but we only have 5,000. So there's a huge gap between the not actual estimated case and actual data set we have. So let's go to the main independent variable. We utilize the US Bureau of the Economic Analysis of Personal Income data to measure the characteristic of the agriculture production. And to capture the characteristic of the increase in the risks due to the agriculture production, not just only their own county, but also their neighbor county. If your neighbor county has a lot of livestock farming, you will get more, your likelihood be exposed to the chemical they use, not just their own county, but just their neighbor county will be increased. We want to capture that neighbor effect or spillover effect, if you say. So to capture the neighbor effect, we employed it. We take the average value for the all contiguous county, not just only counties value. And as I elaborate in the identification strategy, we utilize the livestock sector size and the processing sector size, and just a regular agriculture sector size as our main independent variable. And we introduced several control variable to get the more clear understanding linkage between the agriculture productions and the foodborne illnesses related risks. And we utilize several data sets And first, the data set, we want to measure the accessibility of healthcare. So if someone has a more close access to the healthcare provider or healthcare service, their health condition will be better than compared to the person who could not. So that's our hypothesis, and that's why we included that control variables. And number of the primary case of physicians over the total population is utilized to measure that kind of accessibility of the healthcare. And the second control variable is food insecurity. The person who has no access to the reliable food more likely get more severe health issues compared to the person who can. So that's why we included that measurement. And this can be calculated. This data set we utilize a Feeding American data. So also we have to consider the economic determinants, so economic factor that determines our health condition. First, median health outcome, household outcomes, and unemployment rate has been employed. And we also control the demographic characteristics, which is a population of the age 75 or older. So as I mentioned on the second slide, the older person has a more weak immune system, which means they are more likely to get sick because of the foodborne illnesses. That's why we put the population of the elderly person, and the Hispanic and non-Hispanic Black population has been employed as well. And the last one, but not least one, is the food consumption pattern. As you can imagine that whether the risk of exposure to the foodborne illnesses will be different depending on what kind of food do you consume. For example, I prefer the canned, I prefer processed food, and that means my likelihood of foodborne illness will be different. The person who more likely to consume the fresh vegetable or something. So that's why I use that food consumption pattern as a control variable. And based on our data set, we construct the empirical specification as the following. So let me go quickly. Our independent variable is a foodborne outbreak relative risk measurements. We utilize 4-dimension illnesses, doctor visit, ER visit, and hospitalization. And note that since our data has a lot of zero county observation, as I mentioned before, out of 48 million episodes, we just got 5,000 for the 10 years, which means we have a lot of zero. We have no cases in the A county, B county, C county. So we have to be careful when you deal with that kind of data. Let me explain how to deal with it. Our main independent variable is the following, which is I explained before. Let me skip that one. We included a control variable, which is the other factors that determine the health conditions. And I included a time fixed effect to control for the unobservable time invariant unobservable. For example, macroeconomic shock. So we have to control that one because, for example, Food Modernization Act has been implemented recently, so that could be impact our likelihood of foodborne illnesses because they have a more better policy. That means we have to be careful when we deal with the food and agriculture products. Given the nature of our data, I included Craig double hurdle model. Let me skip what is the double hurdle model in detail, but the basic idea is that we have 2 hurdles. The first hurdle, on the first hurdle, probing model is implemented to predict the zero dependent variable. And at the first stage, we determine only 0 or not as a dependent variable. And second, on the second stage, we determine, okay, this is a non-zero dependent variable. Then how much we have a dependent variable, which means we utilize the truncated normal models to predict the non-zero dependent variable. This is kind of how the two hurdle model works. And same covariate has been implemented in both models. This is our main results. So it seems to be hard to see. So let me zoom in on the main point I want to elaborate. As you can see, the livestock farming, the first law, let's take a look at the second law and third law first. First and third first. And if you take a look at the G livestock, which means livestock sector size, and the agricultural sector size has a positive impact, which means county with a higher level of livestock production and agriculture production are more likely to have a significantly higher level of foodborne illnesses, high foodborne related risks. And we can interpret that result as the following: county with a more animal production and hence more animal waste and associated hazard are more likely to suffer from the foodborne illnesses compared to the county with lesser animal productions. That's one way to interpret the results. And also county having a greater prominence of the agriculture production more likely to experience foodborne illnesses compared to the county having a lesser prominence. Okay, let's go back to the second law, which we can see the negative coefficients of significant results, and processing sector size has a negative impact on the foodborne illnesses, which can be calculated, which can be interpreted as the following: the county with a significant agriculture processing sector activity, processing sector are less likely to expose to the foodborne illnesses. So this may reflect the fact that food and agricultural product processing is likely to be associated with a strong hygiene and worker safety practice, so that can reduce the risks associated with foodborne illnesses. Let me talk about the results in terms of the control variables. So as we imagine, as we expected, elder individual tends to have a weakened immune system response to the foodborne hygiene. And also greater access to the physicians may be associated with a better hygiene and preventative care measurements. That's why we have a significant negative impact in terms of the accessibility to the health provider healthcare service. And also the poor access to the healthcare service among the Hispanic and Black population may lead to the fewer reported foodborne illnesses. It's kind of like hard to interpret at the first time when I got we have a very significant negative impact. So as you can see, the Hispanic Black has a very significant negative impact, which means if Hispanic population has a negative impact of the foodborne illnesses, which is a kind of counterintuitive when I got that results. But I some research review, I figured out that that could be the one interpretation we have it. So our conclusion is our results indicated the agricultural work environmental condition of the county has a significant impact on the foodborne risks. And one contribution we can make is the empirical findings evidenced our understanding of the linkage between agri-food production and the incident nature of the foodborne illnesses. And our policy implication is the following: that there should be the information dissemination effort to the important knowledge to the stakeholder about the importance of occupation hygiene, not just for the worker, but also residents as well, or community they are surrounded by. But we have some limitation. Among the 48 million foodborne illnesses, we only got the 5,000. So it's a huge gap. So limited information in terms of the foodborne illnesses should be considered. And also we utilize to measure the processing sector size. We use the labor intensity as an indirect indicator. But if we have direct data, which is a processing sector sales and the production sector sales, we can better analyze our analysis. Okay, this is pretty much I have. Thank you. Any question?
I have a question. So it sounds like the mechanism that you're looking at here is through the risk to workers, agricultural workers. Does that mean you're able to confine your data set to the foodborne illness outbreaks that happened in people that are working age? For instance, people not over age 65 or not children. Or are you saying that there's kind of spillover to the non-working populations too?
Yeah, that could be the good like data if you have, but we don't have the data because of characteristic of the patients who has more than whose ages and populations and demographic characteristic. We do not have that kind of data, but that could be the good data if you have it.
Then is another mechanism just through the food that people eat in their community, right? That
Right.
like, that the food is also produced there and that they eat it there. So not necessarily through labor markets, but through consumption as well.
Right, that's true. Yeah, when I started this data, when I take a look at this data set, so it seems to be very like a good data, but I figured out 5,000 observation is not enough to be investigated deeply, but I tried to get the more detailed data, and that's why I asked the CDC get the more detailed data. If you go to that website, you can get the like a state level data, not the county level data. But I asked the CDC to share that kind of data, and they are more like willingness to share the data. That's why I got that results. Yeah, we have a question from.
Yeah, I have a question. Just in terms of
Yeah, that I had that your exact same question when I have presented previously. So we don't have that specific location of the processing facility. If you have it, so we can like more like elaborated how the location of the facility will affect the residents' health, but we do not have that kind of informations.
so on the FSI,
They told me that you could geolocate their plants that they on their website.
they just have on the ground.
Oh, okay, sounds great. Yeah, that could be the good like, data set we want to like, incorporate it to the better analysis.
They'll also indicate what type of processing is done in the plant, slaughter or.
Yeah, right. Carrot, right. Right. If you have a distinguished what kind of like a processing, like not just food and like fresh vegetables and meat, that could be the huge difference when we are having like a fresh processing like facility compared to the like other like meat processing facilities. So that could be the like a huge difference if we have just a general like a processing facility compared to the like, specified one. Yeah.
I got a little lost when you were going here. Seems like county size, not, waiting there. Elements that agricultural output. Does that matter at all, or?
Yeah, that's why we just divide by like a county population. We divide by all the levels, divide by the county population. As you can see, yeah, that matters. A scale effect will affect. If you have a large county compared to small county, we have to consider differently. Yeah. Yeah, for example, to measure the measurement of the accessibility of the healthcare, we divide by total populations. That's why we divided and offset the scale effect. Also, yeah, I don't think so we can include it like just a population as another control variable, but if you divide it by all the variable we included as an independent variable, then we can like not perfectly, but we can like control the scale effect like indirectly. Yeah.
I have a comment. If you haven't, Fred Rutschler has an interesting recent paper looking at behavior, looking at the influence of being a food service worker on food safety behavior in your role. So that might be, if you haven't seen that would be worth looking at.
Sandra, I'm sorry, but your voice is echoing. So could you,
sorry,
I
is
guess
it
you have
better?
to, volume down your computer so that it's not echoing.
Oh, I got it. Okay. All right, can you hear me? Can you hear me now?
I can hear echoing voice still. So,
Well, I'll email this to you then.
I'm sorry.
I'll send you an email.
Yeah, I guess, yeah. Sandra, could you put your question on the chat, and I can happily answer your question. I'm so happy I have a lot of questions, to be honest, because previously I didn't get it or not. But that's the beauty of the presenting in person compared to the virtual. So let me say, Sandra say that Fred Cutler has written paper in which he found the food service worker did not use the food safety practice in the home at a higher rate than the general population. Oh, yeah. I haven't read that paper. That could provide another insight. Thank you for your suggestion. Yeah, this is a very interesting topic. I have an interesting paper I have to read. Something to think about, interpret. Yeah, right. It's very hard to interpret when I got the results because of it's very like there's some missing linkage between my results and the data set. Yeah, thank you, Sandra. So any other questions? Okay, so any other question, not for me, the other speaker? Okay, good to go. Have a nice remaining sessions, and hope we can discuss in person. Thank you.